A 60-year-old man presents to the office for shortness of breath. The shortness of breath started a year ago and is exacerbated by physical activity. He has been working in the glass manufacturing industry for 20 years. His vital signs include heart rate 72 minutes, respiratory rate 30 per minute, and blood pressure 130 versus 80 milligram Hg. On physical exam, there are diminished respiratory sounds on both sides. On the chest radiograph, interstitial fibrosis with reticulonodular infiltrate is found on both sides, and there is also an eggshell calcification of multiple adenopacesis. What is the most likely diagnosis? The correct answer is B. The crystalline forms of silica, crystallobilite, and tridymite are associated with a spectrum of pulmonary disease known collectively as silicosis. Workers in a broad range of industry, sandblasting, mining, masonry, foundry work, glass, and ceramic manufacturing are exposed to respirable silica, silicon dioxide. 3 patterns of silicosis have been described as follows. Acute silicosis, also known as acute silicoproteinosis, develops after exposure to high concentration of respirable crystalline silica. Symptoms arise within a few weeks to a few years after the initial exposure. Symptoms include cough, weight loss, fatigue, and sometimes paralytic pain. It is associated with a bilateral alveoli filling pattern, similar to that of pulmonary alveolar proteinosis. Chronic silicosis includes simple silicosis and progressive massive fibrosis has multiple upper lung zone nodules that are rounded and less than 10 mm in diameter. It typically appears 10 to 30 years after exposure. Progressive massive fibrosis refers to coalescing of the nodules of chronic silicosis in association with hilar lymphadenopathy and calcification. Presentations vary from asymptomatic radiographic findings to progressive respiratory insufficiency. Accelerated silicosis develops within 10 years of the initial exposure and is associated with high-level exposure. The radiographic pattern is that of simple silicosis, although the development of radiographic abnormalities is more rapid. Patients with accelerated silicosis are at higher risk for progressive massive fibrosis. The diagnosis of acute silicosis is based upon the history of acute high-dose silica exposure, imaging findings of diffuse nodular and patchy consolidative opposites, a bronchial alveolar lavage effluent that is milky and full of lipoproteins, and exclusion of other potential explanations: infection, pulmonary edema, alveolar hemorrhage, eosinophilic pneumonia, primary pulmonary alveolar proteinosis. The diagnosis of chronic silicosis is based on the combination of the following: a history of sufficient respirable silica exposure to cause the clinical findings, a compatible chest radiograph, and the absence of an alternative explanation. A lung biopsy is reserved for situations in which a confident clinical diagnosis cannot be made. For example, insufficient occupational exposure history, imaging suggestive of malignancy or infection. For all forms of silicosis, further exposure to silica should be avoided or minimized if complete avoidance isn't possible. No specific therapy has been established for any form of silicosis. Symptomatic therapy includes smoking cessation if needed, treatment of airflow limitation with bronchodilators, influenza and pneumococcal vaccines, and the use of supplemental oxygen, if indicated, to prevent chronic hypoxemia complications. As there is no proven therapy for silicosis, efforts should be directed towards prevention through a comprehensive lung health protection program focused on exposure avoidance and use of personal protective equipment. Option A, chronic beryllium disease, CBD, also called berylliosis, is caused by exposure to respirable beryllium metal or alloys, and is characterized by the presence of non-caseating granulomas in the lung. CBD shares many clinical and histopathological features with pulmonary sarcoidosis. Beryllium exposure occurs in various industries, including beryllium and beryllium alloy, beryllium copper, machining, aerospace, automotive, ceramics, computer, defense, and electronic industries. Community-acquired chronic beryllium disease has also been described. Diagnosis of CBD requires all three of the following findings: a history of beryllium exposure, a positive beryllium lymphocyte proliferation test, BELPT, and the presence of non-casseting granulomas and or in the interstitial mononuclear cell infiltrates on lung biopsy. However, if biopsies are not available or are non-diagnostic, the diagnosis can be made based on history of exposure, a positive BLLPT, and imaging that shows abnormalities consistent with CBD. In a patient with a history of beryllium exposure, the diagnosis of CBD should be suspected in the presence of dyspnea, cough, or a chest radiography showing hilarious adenopathy or radicular and nodular lung opacities. A high-resolution computed tomographic HRCT scan is usually obtained to characterize the radiographic pattern and to identify the areas of greatest involvement for subsequent bronchoalveolar lavage or biopsy. Option C. Asbestosis especially refers to pneumoconiosis caused by inhalation of asbestos fibers. The disease is characterized by slowly progressive diffuse pulmonary fibrosis. Exposure to asbestos occurs during the mining and milling of the fiber. In industrial application of asbestos work, for example, work with cement, friction materials, insulation, shipbuilding, and in non-occupational settings with airborne asbestos. For example, regular exposure to soiled work clothes brought home by an asbestos worker, renovation or demolition of asbestos-containing buildings. Most patients who develop asbestosis are asymptomatic for 20 to 30 years after the initial exposure. The latency period between exposure and symptoms is inversely proportional to the intensity of asbestos exposure. The earliest symptom of asbestosis is usually the insidious onset of breathlessness with exertion, which progresses even in the absence of further asbestos exposure. Cough, sputum production, and wheezing are unusual. Typical findings of asbestosis by HCRT include subpleural liner densities of varying lengths parallel to the pleural, basal, and dorsal lung parenchymal fibrosis, with peribronchial, interlobular, and interlobular septal fibrosis, coarse parenchymal bands 2 to 5 centimeter in length, often contiguous with the pleura, coarse honeycombing in advanced disease, and pleural plaques. The diagnosis of asbestosis is based on the following: a reliable history of exposure to asbestos with a proper latency period and/or the presence of markers of exposure, for example, pleural plaques, or recovery of sufficient quantities of asbestos fibers bodies in bronchial, alveolar, lavage, or lung tissue. Definite evidence of interstitial fibrosis, for example, and inspiratory crackles, reduced lung volumes and/or diffusing capacities, typical radiographic findings, or historical evidence of interstitial fibrosis, and absence of other diffuse parenchymal lung disease causes. Option D. Talc powder is composed of crystalline hydrous magnesium silicate. Occupational exposure to talc, for example, ceramic, paper, plastic, lube, paint, and cosmetic industries, can lead to the formation of small rounded opposites in the lung. CT imaging shows small centrilobular and subpleural nodules, conglomerate masses with focal areas of high attenuation, and focal glass opacities. Relative sparing of the lung bases is typical. Talc can be contaminated with amphibole asbestos fibers. These impurities produce additional small irregular opacities and pleural plaques. Option E. Bicyanosis results from long-term inhalation of duct-produced in processing of raw cotton, flax, hemp, and possible sisal. The typical clinical features of chest tightness, cough, and dyspnea that peak 1 to 2 hours into the first day of the work week and gradually decreases throughout the week. These symptoms are associated with airflow limitation on pulmonary function tests. Chronic exposure can lead to a chronic production cough and a gradually worsening airflow limitation, resembling chronic bronchiolitis. but it is not associated with radiographic abnormalities. Learning objective: the crystalline forms of silica, for example, quartz, crystal bilate, and chidemite, are associated with the spectrum of pulmonary disease, known collectively as silicosis. Excuse me. Workers in a broad range of industries, for example, sandblasting, mining, masonry, foundry work, glass, and ceramic manufacturing, are exposed to respirable silica, silicon dioxide.